to be here. It's a great honor for me to be here. And it's really, a number of coincidences that I'm here, in fact. I know you want me to talk about the perimenopause and migraine, but ironically, I got interested in migraine because it was the men in our family who had migraine. Now, some of the women had it, but it was the men who had it really badly. So without further ado, we'll get started on the topic in question. And again, thank you for the invitation. And as Saeed, as we mentioned, I'm a GP with an extended role. I'm also involved with the European Reference Network for Rare and Complex Neurological Disorders. And I've been involved with the Cochrane Collaboration, which is also a research body. And I've done a Cochrane review on a rare disease. My background is that I spent more than 20 years in Dunlavin, and the opportunity presented itself for me to take a step back from full-time practice, and it gave me the time to concentrate and upscale in headaches, which is what I've done. And just to get over the formalities of the presentation, I've no financial interest to declare or with regard to any of the subject matter on the topic tonight, and the information is accurate. And obviously this presentation is no substitute from attending your own GP, and it's for information only. Well, as we've seen in the last few episodes that the Migraine Association of Ireland have presented to us, that migraine is a huge problem. And I don't need to elaborate on this, but quite often, I mean, even recently I was taking a history from a young girl, and her mother and her father were there, and they said, oh no, nobody really has migraine. And I happen to know one of the parents quite well. And I said, well, I think your brother had a migraine and your sister had a migraine. And then the mum says, well, I had a migraine one day, but it never came to anything. So that really tells us that migraine is very common. 42% of all women will have a migraine sometime in their lifetime. But of course, thankfully, it's not really bad for some people, but for some people, it really is. It's really, really common, and this was also discussed last week, in that it's second to back pain in the years lived with disability. And my goodness, it can be some disability. Hormonal factors is what I've been tasked to do with in the past, and today as well, some hormonal factors, but there are several areas where there are hormonal factors. The boys, even between 8 and 15, migraine is more common with them, and there's hormonal factors involved. The teenagers, my goodness, that's an area I think is quite neglected. And then you have the menstrual cycle and pregnancy and breastfeeding, and we won't dwell on them in any detail this time. But we've the perimenopause, and the perimenopause is before the menopause. And the perimenopause, really, estrogen levels are very erratic. And, we discussed this in detail. And postmenopausal, the levels have dropped, but they're stable. So these are you can see here in the red, the perimenopause and the normal reproductive life, or premenopause, my apologies, premenopause, and then you have the perimenopause and the menopause. So premenopause estrogen levels are sliding a little bit, but not too bad. But when you get as far as the perimenopause, they're going down a lot more, and then the menopause. But really, it's if you can keep the levels stable, that's really the trick. So what age are you more likely to get migraine? Well, you're more likely to get migraine as you're a teenager and up until your 20s. Now, there are lots of people get migraine in their 20s, but there's just not as many of them getting migraine in their 20s as there is in their teens. But you can see from 35 to 43 or 4, there's more people getting migraine. In fact, what they say is there's more people in their late 30s have migraine than at any other time. But as I said, this graph only shows you the age you're more likely to get migraine. So in order to understand what happens in the perimenopause and the menopause, we really need to look at how things are before that time and how the estrogen level varies every 28 days for women between the ages of 18 to 49. Now, there are 3 different ways that a woman's menstrual cycle migraine can affect a woman's menstrual cycle. And we will be talking about them in detail. But first of all, we need to look at what happens usually. So this is the normal menstrual cycle. And day 1 here is the first day of your period. So as the period weans off, the estrogen level starts to rise. And of course, it rises if you have an ideal 28-day cycle. It's at its max about day 14. And as you all know, I suppose that's the time you're more likely to become pregnant. You have a little bit of a dip in the estrogen at day 14, day 15. It stabilizes a little bit. But your next period is going to be due here. And you can see for the 3 or 4 days before the period, the estrogen is falling. And that's really important to remember in the context of migraine. Now, there are a couple of other hormones as well that are involved. And I just show you the estrogen again. That fall is actually more exaggerated than it actually is. It really only falls to there and then goes gradually down. But you can see it's the same general principle. The progestogen is here. The progestogen in the first half of the menstrual cycle is lowish, and then in the second half, as it prepares the womb for the fertilized egg, it increases, but then when the egg isn't fertilized, it drops off. And this is all based on the ideal 28-day cycle, which of course we all know doesn't happen all the time. The other main player I want to talk about is the FSH. And as you can see, the FSH rises just as the estrogen is rising, and then as it rises to a height, and then the estrogen falls, and so does the FSH. So we'll talk about that later. So what are the functions of the estrogen? Well, the main one is the growth and repair of the lining of the uterus. And as I said, when the estrogen level rises, the FSH level falls. And this is the problem in the menopause. We'll be touching on it at length because the estrogen level is going to be low and the FSH is going to be high. And when the estrogen level rises high enough, it causes a surge in the other pituitary hormone, the LH, the luteinizing hormone. And the LH surge causes ovulation, where an egg is released from the follicle and helps with assisting in pregnancy. Now, estrogen, not alone is it involved in the uterus and in preparing the uterus for the fertilized egg, but it's also involved in the bones, as I'm sure most people are aware. Blood vessels, skin, it gives us that nice skin, and our skin, of course, deteriorates as we get that bit older. The heart, the brain, and the breast. And before there's anything about the menopause, this is the average lady in her 20s, 30s. There's a nice regular pattern here every month. And you can see the red is the estrogen. It lowers a little bit at ovulation, then really lowers. And you can see the curve on this one is slightly different than the other one we had before. But it's this general principle. The FSH, it rises mid-cycle and it falls again. And it's the LH, you can see the surge of, that's the one that prepares the fertilized egg for going on to the womb. So progestogen prepares the body for pregnancy in the event that an egg is fertilized. And if the egg is not fertilized, the corpus luteum breaks down and the progestogen falls and a new cycle happens again. Progestogen is important, but it hasn't to date got the same emphasis as estrogen. And this is just to remind you the up and down of what happens in the menstrual cycle. So the functions of FSH, this is the really one for the menopause. It stimulates an ovarian follicle, causing an egg to grow. It triggers the production of estrogen, and the rise in estrogen tells the pituitary gland to stop producing the FSH and to start making the LH. And it's this mechanism in the menopause that really causes the woman so many symptoms, because you have the FSH is stimulating the follicle to produce estrogen, but of course the follicles are, gone past their best, so to speak, and there's no And just to recap, the 3 ways that migraine is affected by menstruation. Now, I have to tell you that there's a huge, big 300-page classification of migraine. And menstrual migraine problems are in the appendix. And the appendix is the area which has conditions which need more research. So there needs to be a lot more research conducted in menstrual migraine. And these are the 3 different ways that for most women between 18 and 40, maybe 45, and sometimes older, that migraine is affected by menstruation. You have menstrually related migraine. Is you get attacks during the period, and you also get attacks at other times. And this is the most common at 66%. And then you've pure menstrual migraine. Now, this only occurs in 5 to 15% of women, but attacks occur only on 2 days before to 3 days after the start of the period. And it's typically migraine without aura. Now, you know, and then we have non-menstrual migraine, which you can get, it's not related to periods at all, and you can get attacks at any stage. I just want to say that, you know, you might think you've menstrually related migraine, and if your control improved, you might go into the pure menstrual category, the pure menstrual migraine category, or you might be in the pure menstrual migraine category and you might go to a different one. Over the years, I have seen when I get people to take the relevant precautions and do different things to help themselves, they often transgress from the first category into the pure menstrual migraine. And the reason this is so important is that there are treatments which really help pure menstrual migraine that don't do as much for the other types of migraine. And as you can see there, these conditions need a diary of a minimum of 3 months before they can be diagnosed. You cannot come into a doctor and say, oh, well, I generally get it around the time of the period. The doctor will say, I need to see your diary. And this is international good practice, and it's expected of all doctors in this day and age. So of the 5 to 15% of women, the menstruation is clearly a trigger because the estrogen level has fallen. Men don't have this trigger. But I would like to remind you, as Nurse Esther Tompkins said last week, that stress is a bigger trigger than hormones. And you can see this from the slide, that 80% of migraine is triggered by stress, whereas only 65% is triggered by hormones. But 65% is a considerable amount of people. And I do want to just say a few words about triggers of not eating. I mean, a regular lifestyle and regular food is really important. And you can see there, not eating triggers migraine in 60% of people. You know, a sensible, regular diet is so important. So what is the difference between this pure menstrual migraine and ordinary migraine? Well, the attacks are more severe and more difficult to treat. And this is where the women really get frustrated, that their usual preventatives are not working at menstruation and they're miserable. Now, if sumatriptan is not working, the option is to consider frovatriptan or naratriptan as their longer acting triptans, and they usually work better at this time. But hormones, this would be acute treatment. Hormones are considered preventative treatment, and they also work very well in pure menstrual migraine. So what you're trying to do in pure menstrual migraine is stop the ovulation and stop the cycle of the changing estrogen levels. You can do a progesterone only pill. It's a tablet, desogestrel, and you take it daily at the same time every day, and it usually helps the migraine and stops this hormone seesaw. You could have the long-acting injection, a 3-monthly injection, or the implant, a progesterone implant in your arm. Now, these approaches can be used in menstrually related migraine, but very particularly in pure menstrual migraine. You also might consider having a non-steroidal anti-inflammatory plus a triptan ready by the side of the bed if you waken with a headache and the period is due. The only problem with having them beside the bed is that really the non-steroidal anti-inflammatory is better taken after food, but that can be problematic for some people who've nausea. In America, what they're doing now is they have a tablet which contains both naproxen and a triptan, and they've marketed that for migraine. And in fact, I think it's available across the counter. You could have your long-acting triptan though beside the bed, or if you knew and had a reliable cycle, you could even take it before you go to bed, if you knew the period was expected. You could also increase your regular preventative medication before menstruation. And here we're talking about things like beta blockers or amitriptyline. And some women find taking magnesium from ovulation until menstruation is stopped is particularly helpful. So there's quite a few things you can do. You shouldn't do all new things at the one time. You should sort of space it out for different times. So we're trying to create that we'll have unchanging female hormones, but we can never forget about the other factors in that precipitate migraine, because even if we have the unchanging female hormones and we're getting up at 4 o'clock in the morning, it can trigger a migraine. So what happens to estrogen level if you're taking the pill? And this document shows you, as I'm sure you're all familiar, that you take the pill from day 1 to day 21. So then your hormones just drop, and then, you know, you'll have the period during this time. And the worst day that migraine tends to happen is that about 3 days after you stop the pill, that you can get a migraine. And I always advise people, if they get a migraine in the pill-free time of their ordinary pill, they should really consider changing their pill. Excuse me. And this will show you how things seesaw, but there's nothing, it's a lot more stable sometimes than if you had a normal menstrual cycle. You don't get the changes in the estrogen quite so much. And this is very interesting. I had a lady who came to me, and she'd been on the pill for a number of years, and she'd 3 pregnancies in quick succession. And then she wasn't taking any contraception. And of course, she was blaming all sorts of things for causing her migraine, when in fact, she always had migraine, but the pill actually had helped her migraine so well, she didn't realize what she had missed until she came off it. So what you could do if you are on the combined pill is you could continue taking the pill for 6 packets. Well, normally we say 3 to 4 packets, and you can take no break. You are at risk of getting a headache after you take 3 to 4 packets. Sorry, we have to go back to apologies there. I've just corrected the previous slide. Usually we recommend to take the combined contraceptive pill for 3 to 4 packets and taking no break to keep the hormones stable. You are at risk of getting a headache after you've taken the 3 or 4 packets, but you know, you could get the headache and then have take another 3 or 4 packets continuously. So it could very well reduce your headache risk. So let's get on to the perimenopause. And is it worse than the menopause? Well, the perimenopause is that transition between those normal, predictable changes in the hormone to something that's very unpredictable. And yes, unfortunately, it generally is worse than the menopause, as in the menopause, as we saw in the very beginning, the female hormones are more stable. And this gives you an idea of what happens. I mean, there's no regularity here. This is 6 months of the hormones in the perimenopause stable. And really, there's no regularity. And just by comparison, this was in the normal woman between 18 and 37. This was her regular hormones. And as we alluded to earlier, the FSH is raised, and it's the one that's causing the effects. The raised FSH causes the hot flushes, and the FSH levels are often used to measure when the menopause has actually occurred. If it's greater than 30 IU, taking twice, with 6 weeks apart, then it's accepted that the woman has reached the menopause. So in fact, most people will be hoping they've got to the menopause rather than in this perimenopause phase. So how does it start? Well, it starts with the irregular periods and the irregular menstrual cycle due to declining function, and it ends a year after the last menstrual period. The length varies from one woman to the other, and it can be 3 or 4 years, or it can be a lot longer. So the hot flushes, the heavy irregular periods are often troublesome, while others may, some people will have very light periods. Recently, I read where women in Africa tend to have less trouble in the perimenopause than in the Western world. And the main difference they see is that if women are walking, a lot of women in the Africa have to go walking for food, and that the women who don't go walking in Africa suffer a lot more in the perimenopause. So perhaps this is something for us all to think about. And particularly, I think, when I say to you to walk early in the day. So the hot flushes and the night sweats are due to this raised FSH level. And your body's thermostat is in the hypothalamus, is in the brain. And, you know, it thinks your body is too warm. So it starts this chain of events to cool you down. And after the perimenopause, you can still get hot flushes, but usually it's precipitated by hot food, coffee, or alcohol. It's not the night sweats that you suffer in the perimenopause. There are several symptoms, but I keep harping on about the hot flushes, the night sweats, and the dry vagina, because they're what we call in medical terms the cardinal symptoms. The less specific symptoms are the sleepless nights. Well, of course, they'll come with the night sweats. The mood changes, the weight gain, the breast pain, and the joint pain, and the headaches. So what happens to the migraine frequency? Well, the hormones are fluctuating an awful lot more than pre-perimenopause. The estrogen level is dropping. And as we saw earlier, the estrogen level tended to prevent the migraine. So you have fluctuating hormones, estrogen level dropping from its baseline, the levels are erratic, and the migraines are worse. And then it's a catch-22 situation. You're not sleeping, and that's not helping your migraine. And you're not sleeping because of the perimenopause, and then you have the migraine. So what do? And you're also more likely in the 40s to have pre-existing blood pressure, maybe a bit of stress and depression. And all these things work synergistically and really increase the burden of migraine. So what can you do? Well, if you really have the hot flushes, the night sweats, and the dry vagina, HRT is often indicated. And a combined continuous hormone replacement therapy is preferable. That would be an estrogen patch, which is even easier to use than the gel, because you know you're after having your shower and you're rushing out and you're putting on a bit of gel, and did I put on enough? Is it absorbed properly? Have I done it right? And then most people, if they have a womb, should be taking progestogen, and sometimes the doctor will advise progestogen from day 12 to day 14 to day 28. But really, you might be better to take progestogen all 28 days and take it daily to try and prevent hormone fluctuation. But using HRT purely for migraine in the perimenopause is not recommended. HRT is for menopausal or perimenopausal symptoms, which are again the hot flushes, the night sweats, and the dry vagina. So what else can we do? Well, we could take the desogestrel, the progestogen-only pill. We could try the progestogen-only injection, because it really switches off the menstrual cycle. But do keep in mind to have a DEXA scan done before getting this injection, particularly at this age group, to assess the bones. And you'll remember earlier, we talked a bit about the effects estrogen has on bones. And with your estrogen level lowering, your bones are more brittle, more likely to get brittle. And the DEXA scan is a preventative measure at this stage to assess the bones. What else can be done? Well, there are lots of other things. Don't forget your regular preventatives. Get your blood pressure checked. You know, there are two very good drugs for migraine and that help blood pressure and migraine, the beta blockers and the candesartan. And there are quite a few beta blockers even available within the range. If you're on topiramate, don't come off it. Think about amitriptyline, because it helps both sleep and migraine. And venlafaxine is great. It can be used for anxiety, and it can also help the migraine. And the newer CGRP drugs are coming on the market and are showing great hope. But please remember your triggers. If your triggers are not continuously reviewed and looked at, things will go awry, no matter what drug you take. So as we said, keep the blood pressure normal. Get the natural light in your eyes in the morning, because it raises your hormone levels for the day and gets you going. They say particularly early morning light. And think of those women in Africa who are walking on a regular basis and are trying to, and it is helping prevent perimenopausal symptoms. Perhaps think about walking rather than taking your car. A very topical thing during COVID times is using screens and computers and the different things. And I think, Saif, you might like to say a few words here. You've got a lot of information about computers and things people can do to help themselves at this time.
Yes, thank you, Mary. I think, the past year there's been huge increase in screen time, be it if you're working from home or students that are also homeschooling. So one thing, a few tips that we would share with you is to ensure you've got good posture at your desk. So you've got a good desk height, you've got a good supporting chair. Take regular breaks from your computer screen. So if you have classes or you have meetings via Zoom and Teams and different things, even try and turn off your camera for a while, face away from your computer, and treat it almost like a phone call to give yourself a break from looking at the screen. And you can consider maybe tinted lenses or glasses to help with glare and blue light. I know there's Perspex are a company that would have a range of those. You can also fit anti-glare or blue light filter screens over your computer, or also you can download apps for your phone. I know there's Flux, F.lux, there's OcuShield, and there's twilight and blue light filter apps as well for your screens. It's important to turn off, overhead lights or lamps that could be affecting with the flicker. Don't try not sit towards glare. Don't sit facing out the window. That can affect you. Try and take small regular breaks, even just to get up and walk and stretch and a little bit of fresh air. As Mary said, remember, eat regularly and keep hydrated. And we tend to, working from home, work longer hours and maybe not taking breaks as much. So even setting little reminders on your phone when to eat, and just try to remember to keep your regular routine as much as possible. But for any more information on this, we do have a lot on our website. You can just type in visual stress, light and migraine, or you can always send us an email as well if you'd like more information.
Well, Saif, that's been very helpful. I've even got a few tips myself there, and I think they're really important, and particularly in the times that we're in just at the minute. So we are. One other area that's caught my attention recently is yoga, and there seems to be a lot of talk, and even in the medical world, yoga slows the heart rate, respiratory rate. And these in turn help to modify our reaction to stress. And, this can further reduce your chances of getting a severe migraine. So it's well worth considering, and it's not a medication. And we all know that medications have side effects. So what's the menopause? The menopause is described as the absence of menstruation for 1 year. Usually happens about 53, but of course it may be earlier or it may be later. So how is migraine affected by the menopause when it actually gets to the menopause? Well, 60 to 70% of people actually improve. So the menopause is really not to be feared, particularly if you're one of those people who's got pure menstrual migraine. Now, not all women have pure menstrual migraine, but some of you will also have the menstrually related migraine. And the menopause is a time when you will improve. But there again, if you don't consider your stresses, consider your triggers, you will have migraine again. And this is the hormone pattern in the menopause, and everything is just deadpan, dead flat. And you can see it's such a difference to the perimenopause when it was all over the place. These are just showing you the three of them. This is the top one is for the younger woman between 18 and up to 40. And the perimenopause, it's really topsy-turvy. And of course, the menopause, you're home and dry at that stage, and hopefully much better. So what happens if you have a hysterectomy? Well, the hormones can fluctuate significantly, and you can get you know, it doesn't turn off your pituitary hormones. Your FSH can still cause hot flushes, and you can have fluctuating estrogen levels because you have your ovaries still. So it does take a little while to get them settled down, and it's not uncommon for people to go on HRT if they've had a hysterectomy, if they've had their ovaries removed, and we call that a surgical menopause in medical terms. 40 to 70% of people worsen. Because it doesn't block this pituitary axis, and we still have the FSH. So it's generally considered to start HRT if you have the ovaries removed, and you would do it for a number of years. There again, getting out walking during the day and getting out particularly early in the morning is particularly useful. But no matter what age you are, I'm sorry to keep stressing this, mind the triggers. And I always like to remind people, it's not just one thing. It's not just the row at home with the daughter, the period, the stress at work, but it's just all those things together. So if, you know, one thing you'll probably tolerate, but not a whole ton of them. But don't feel guilty if they just come on for one reason, for no reason. I mean, sometimes you just can't help it, and sometimes they just come on for no reason, and it's important not to upset yourself and feel guilty about it. So how does the HRT affect those with migraine? And you can see there it's a variable effect. The chances are you won't be any worse, but of course you could be one of those unlucky people, 1 in 4, where it may make you worse. But the chances are, if it's given for the proper reason, it won't make you any worse. So we'll just summarize things again. Continue on your usual preventative medication. That's your beta blockers, your candesartan, your topiramate. Stabilize your estrogen level if at all possible. If you have the hot flushes, the night sweats, and the dry vagina, consider the HRT. Look after your general health, and I really want to emphasize this. Look after your blood pressure, and if anxiety and depression is there, think about taking something. There are 2 or 3 drugs there which help migraine and help anxiety and depression. Consider the triggers, eating regularly, and you take some advice there from SIVE at the Migraine Association of Ireland about the different things you can do with the computer use, exercise early in the day, and consider yoga. And some of these are really cost-effective options. They're not expensive. More of them are expensive. And really, I suppose the cost-effective ones are the ones we should be thinking about first. As well as that, in the green environment that we live in, we should be also thinking about them. So what if you can't take the HRT for some reason? Well, the venlafaxine or escitalopram is often used, and the venlafaxine in particular helps menopausal and helps migraine symptoms. And migraine symptoms can change over a woman's lifetime. And you can change, as I said earlier, from even pure menstrual migraine to menstrually related migraine, or vice versa. Now, I have specifically really avoided talking about the progestogen coil until this. And, you know, there's several different medical opinions. As I often say, if you ask 10 medical doctors this question, does the progestogen coil affect the migraine? 5 will say no, and 5 will say yes. Even the experts, as you can see there, hotly debated this at the European Headache Federation conference. And in summary, what I'd say is, for some people it makes you better, for some it makes you worse. But certainly in my clinical experience, I have seen the coil affect quite a few people, giving them headaches, and some others making their migraine worse, and they've improved when the coil has been removed. But for some people it does help them. What acute treatment? Well, the acute treatment, you know, we have the usual acute treatment, and this is dealt with in a different webinar with the Migraine Association. And we'll have Dr. Martin Rutledge talking about preventative treatment on the 31st of March. And I'm sure he'll enlighten us all. So thank you very much for your attention. And it was a great honor to talk to you all tonight. And I'm delighted to have the opportunity, and I hope you will be able to gain some benefit from it. I would like just to say at this stage that the document on the Irish College of General Practitioners website that SIVE mentioned in advance of the presentation is freely available to everybody to download. if you go to www.icgp.ie and put migraine into the search bar, you'll be able to access the document. So thank you very much again for your attention, and thank you again to the Migraine Association for facilitating me to talk to you all tonight.
Thank you so much, Mary. As always, your knowledge and expertise in this area really is amazing. And I know for everybody listening, it's really, really appreciated.